This is a short presentation for the drugs that we can use for cancer pain. Analgesics are the most powerful types of pain medications that we can use to overcome cancer pain. And if we use it properly, meaning we're prescribing properly, the patient's administering it properly, it can relieve the pain that's experienced by 90% of the cancer patients. They're so effective that the drug therapy principal modality is around analgesic for pain treatment. And there are three types in which you can use. You can use the non-opioid analgesics, the opioid analgesics, and the adjuvant analgesics like glucocorticoids and biphosphonates as well. In terms of the non-opioid analgesics, those are going to be your NSAIDs, your acetaminophen. The opioid analgesics that are most commonly used to treat cancer pain are oxycodone, fentanyl, and morphine. Selection among the analgesics is going to be based on what type of intensity and what type of pain your patient is experiencing. And in your textbook, you can see a drug selection ladder that was outlined by the World Health Organization to help you understand what pain medications should be used for mild to moderate versus the second step of severe pain and also moderate strength pain. And it goes up to severe pain as well. Now, adjuvant analgesics are especially effective against the neuropathic pain, and this is also another step of that ladder as well. Now, traditionally, patients have been given opioid analgesics only after a non-opioid has failed them. However, the guidelines from the National Comprehensive Cancer Network, or the NCCN, they actually recommend a different type of approach in treating cancer pain. And it's based on the pain intensity. Specifically, if the patient reports, let's say, already a range of like 4 out of 10 pain, then you go directly with the opioid instead of starting first with a non-opioid, because we're already past that on the 0 to 10 pain scale. Another example is if the patient reports a pain in the 1 to 3 range, then you would start with the non-opioid, and usually it's going to be an NSAID or an acetaminophen. And if that works, we stay there, but if it doesn't work, then we scale up to an opioid type analgesic as an alternative. It's common practice to combine opioids and non-opioids because the combination is going to be more effective than just using one or the other. When cancer pain is only moderate, opioids and non-opioids can actually be used in a fixed dose combination, and this simplifies your dosing. So be aware that this is an option for you. However, when the pain is so severe, you give them separately because you might need to increase the opioid, and maybe there's a side effect of the non-opioid and it becomes intolerable at a certain dose. So then you're only giving the dose of the opioid that's increased, or vice versa. You want to adhere to some very good principles for prescribing for cancer pain. First, perform a comprehensive pre-treatment assessment. You want to identify the pain intensity and try to figure out the underlying cause where it's being derived. You individualize the treatment plan. You should use the WHO analgesic ladder and the NCCN guidelines. Try to use oral therapy whenever possible, and you want to avoid intramuscular injections whenever possible. And I want you to think about this reasoning for a bit. For persistent pain, you're going to give analgesics on a fixed dose, so around the clock, We also call this ATC dosing, around the clock. And you're going to provide rescue doses of short-acting breakthrough type medications if that breakthrough pain occurs. If there's a particular activity that's associated with the breakthrough pain, for example, if they're doing one of their ADLs, like taking a bath or ambulating, then you might give an incident dose of the short-acting medication before that activity. And last, evaluate the patient frequently to understand their level of pain relief and any drug side effects that they might be experiencing. It's also important to understand which drugs are not recommended for treating cancer pain, and you can see the drug class, the drug itself, and why it's not recommended. So for an example, using a pure opioid agonist is not recommended. These drugs are meperidine and codeine. Meperidine actually will cause an accumulation of the metabolite that becomes toxic. And codeine, the maximum pain relief is very limited, and this is because the dosing itself is very limited. With the opioid agonist and antagonist, there isn't a ceiling to the analgesic effect. And when you give this medication, it can sometimes precipitate withdrawal in opioid-dependent patients. You might even have psychotomimetic reactions. With opioid antagonists, remember these are things like Narcan, they can precipitate withdrawal in opioid-dependent patients as well, and they can limit the ability to reverse life-threatening respiratory depression caused by opioid overdose. Benzodiazepines are not recommended for treating cancer pain. They also limit the opioid dosage, and there's no demonstration that it actually will provide an analgesic action. Barbiturates can cause sedation, limiting opioid dosage, and it doesn't demonstrate analgesic action as well. And lastly, marijuana can cause specific side effects like dysphoria, drowsiness, hypotension, and bradycardia, and should not be used as routine analgesics for treating cancer pain. So first we'll talk a little bit in more detail regarding the non-opioid analgesics in terms of how they can be used to decrease cancer pain. They are the first rung of that ladder that the World Health Organization has provided, that analgesic ladder. And we should be using these first as initial drug of choice for patients with mild pain. And there is a ceiling to how much pain relief these NSAIDs and acetaminophen can really provide. And there's no benefit to exceeding the recommended dosage, which also, in terms of provider prescribing, you should not do anyways. Acetaminophen is about equal to NSAIDs in terms of the efficacy of the analgesic effect, but remembering that acetaminophen doesn't provide any anti-inflammatory action. Because of this difference, acetaminophen we're going to actually talk about a little bit later in more detail. You also can look up in your book the chapters that are specific to NSAIDs and acetaminophen. With NSAIDs, they can provide a variety of effects for our cancer patients, but beneficial effects primarily are going to be the pain relief, the suppression of inflammation, and the reduction of fever that can also be secondary to our patient's cancer. The primary adverse effects that you want to recognize are the risk for gastric ulceration, acute renal failure, and bleeding. And just like all NSAIDs except for aspirin, they increase the risk for thrombotic events like MI and stroke. In contrast to opioids, NSAIDs do not cause dependency or tolerance. So there's no physical dependency or psychologic dependency when using NSAIDs. They are effective, they relieve mild to moderate pain, and all of the NSAIDs have essentially an equal analgesic efficacy. There's not one that's really better than the other. It's what your patient responds to best. They relieve pain by a mechanism that's different than opioids, remembering that they work on the COX, and this is inhibiting the cyclooxygenase, which is COX. So they're COX inhibitors. Now remember, we have good and bad COX, and they will inhibit both COX-1 and COX-2. And most NSAIDs inhibit both COX-1 and COX-2, but there are a few that are very selective and only will work on COX-2. The COX-2 inhibitors, that is Celebrex or celecoxib. And celecoxib can actually be very helpful because they cause less GI damage than the non-selective inhibitors that work on both COX-1 and COX-2. Unfortunately, the selective inhibitors can pose a greater risk, though, for thrombotic events, and that's why we don't recommend using Celebrex for our cancer patients. Choose a COX inhibitor that is working on both COX-1 and COX-2. For patients that are going through chemotherapy, inhibiting platelet aggregation by using NSAIDs can be a serious concern. There are many anti-cancer drugs that suppress bone marrow already, and they're already decreasing your platelet production. And so if you're using a bone marrow suppressive drug, in addition to an NSAID that's inhibiting platelet aggregation, you can cause thrombocytopenia, putting your patient at risk for bruising and bleeding. This is very important. And obviously the risk is going to be increased if they're using a drug that inhibits platelet function. Among the conventional NSAIDs, there's one subclass, the non-acetylated salicylates, like magnesium salicylate, that does not inhibit platelet aggregation, and it's safe for patients that have underlying thrombocytopenia because of their chemotherapy and other cancer medications. All the other conventional NSAIDs need to be avoided for patients with thrombocytopenia. Aspirin also should be avoided because it can cause irreversible inhibition of platelet aggregation. Again, that's irreversible inhibition of platelet aggregation. If the effects persist, it will persist for the life of the platelet, and that's about 8 days long. Because the COX-2 inhibitors do not affect platelets, actually, Celebrex would be a drug that's preferred and is safe for patients with thrombocytopenia. So returning to our conversation about acetaminophen, we know that it differs from NSAIDs again because it doesn't inhibit COX, and acetaminophen doesn't have the anti-inflammatory actions that NSAIDs do. They also don't inhibit platelet aggregation. They don't promote gastric ulceration, renal failure, or thrombotic events. Because acetaminophen doesn't affect platelets, this is good for a patient with thrombocytopenia. However, there are some important interactions with the acetaminophen and other drugs. Alcohol and warfarin, which are anticoagulants. If you combine acetaminophen, so Tylenol, with alcohol, even in small amounts, it can result in potential liver failure. Patients that are taking acetaminophen should minimize their alcohol consumption altogether. It also can increase the risk for bleeding in patients that are taking warfarin. Okay, so think alcohol, warfarin, not with Tylenol. The mechanism appears to be that with warfarin, there's an inhibition of warfarin metabolism that causes warfarin to accumulate to very toxic levels. Now, there is evidence regarding the use of bleeding with acetaminophen in patients that are taking warfarin, but it is scarce. Although it's very prudent, I would say, to recognize that you need to increase the monitoring of your patient's INR if you are going to prescribe scheduled acetaminophen for their pain relief. Opioid analgesics are the most effective analgesics that are available, and they are the primary drug for treating moderate to severe cancer pain. And if we're using the proper dosing, it can be relatively safe. Unfortunately, many patients are denied adequate dosing, and this is because there's a fear of, by the patient or the provider, or a combination of both, that there's going to be a fear of addiction or dependence. There's a variety of pharmacological effects that we've learned earlier this semester. In addition to analgesic effects, they can cause sedation, euphoria, constipation, respiratory depression, urinary retention, and meiosis. And when you use opioids continuously, it could develop intolerance and other effects, with the notable exception of constipation and meiosis. Continuous use results in physical dependence, but this doesn't mean addiction. Physical dependence doesn't necessarily mean psychological addiction. Go revisit the chapter on opioids for more information. Remembering that the mechanism of action is to relieve pain by mimicking the actions of our endogenous opioid peptides. Enkephalins, dynorphins, endorphins. Primarily, it's working on the mu receptors and partially on the kappa receptors. So based on the actions at the mu and the kappa, the opioids that we can use are going to fall in two major groups. We have the pure agonists, or full agonists, like morphine, and then we have the agonist antagonists, like butorphanol. The pure agonists can be subdivided then into drugs that are used for mild to moderate pain and those that are used for moderate to severe pain. And these pure agonists, they act on the mu receptor and the kappa receptor. However, the agonist antagonists, they act as agonists only at the kappa receptor. At the mu receptor, the drugs are antagonists, and that's why they're called agonist antagonists. So agonist at the kappa, antagonist at the mu. Because their agonist actions are limited at the kappa receptor, the agonist antagonists have a ceiling to their analgesic effect. These agonist antagonists can block access of pure agonists to the mu receptors, and that's why you don't want to use agonist antagonists for managing cancer type pains. Now, the tolerance and physical dependence over time can occur. However, to some degree, the tolerance and physical dependence will develop after 1 to 2 weeks of opioid use, and tolerance and physical dependence and addiction are further discussed in the previous chapter on drug dependence. This phenomena is generally inseparable, the tolerance and physical dependence. And it's reflective of the neuronal adaptations that occur in our body when we are exposed to opioids for long amounts of time. So how do we decide what drug to use? What is the preferred opioid? And so for all our cancer patients, pure opioid agonists are preferred to the agonist antagonist, and we discussed why, right? Because they can prevent the pure agonist from relieving pain. So we want to use and try to choose the pure opioids. If pain is not too intense, using a moderately strong opioid like oxycodone is appropriate to prescribe. If pain is moderate to severe, you might need to use morphine. However, morphine is inexpensive. It's also available in multiple doses. We understand it very well clinically. So most providers are comfortable prescribing morphine. You can see a detailed list in your book under the drug selection of preferred opioids. There's also this concept of opioid rotation, and this is when we switch from one to another. And it's more acceptable practice now than before because there's more research. Because opioids have different side effect profiles, rotating them can help to minimize the adverse side effects that would occur with the accumulation of these drugs over time. and it can still help maintain good analgesia to your patient with cancer. And so when you're making the switch, the current opioid is going to be stopped abruptly, and then immediately you're going to replace it with the equal analgesic dose of something alternative, so an alternative opioid. Equal analgesic dose meaning you're providing the same dose amount that would give the equivalent analgesic effect as the previous opioid. You want to use methadone and lefluronidase with caution. If you're going to use it, you have to understand that these drugs have prolonged half-lives, and it really makes titrating the dose very difficult. So if you're not skilled at using these drugs, then you should probably refer out to someone else that's more skilled at using these drugs or prescribing these drugs and very comfortable. Because if you're not dosing correctly, they can accumulate to dangerous levels, and this would cause excessive sedation and respiratory depression for your patient. Methadone should be limited to those with specialty training, and actually using and dosing methadone, you do have to go through some extra training and certification. Now, codeine deserves also a special comment here. I did mention this earlier, but just to say it again, codeine is capable of producing a significant amount of analgesic effect, but the side effects limit the dose that we can use. And as a result, then we can't really dose high enough to relieve the pain. Meperidine, a pure opioid agonist, can be used for a few days, but really it shouldn't be for long term. And most patients don't do well on meperidine for cancer pain, because if you think about the toxic metabolite, normeperidine, accumulating, it can pose a risk for CNS effects like dysphoria, agitation, and seizures, especially in our older patients. And most of the time, our older patients are those that are experiencing cancer. It is a drug that I don't use for cancer patients. The agonist-antagonists, buprenorphine, butorphanol, nalbuphine, and pentazocine, these can be avoided also. And there's several reasons why. First, they're less effective than the pure opioid agonists. So why would you use them? You have something better to use. But also, patients that are physically dependent on pure opioid agonists, these drugs will actually prevent that pure agonist from working. And it's blocking the analgesic effect, which will then, if it's blocking the analgesic effect, it's going to promote withdrawal symptoms. Also, agonist-antagonists can cause adverse psychologic reactions like nightmares, hallucinations, and dysphorias. So, do not prescribe the agonist-antagonists or meperidine. If for whatever reason you are noticing side effects with your patients that are derived from opioid use, like respiratory depression, constipation, sedation, sometimes orthostatic hypotension, meiosis, nausea, vomiting, we can still manage it. Many of these patients, if we decrease the dose, and usually we try to use a rule of decreasing it by 25%, that will decrease their side effects. However, if this reduction causes pain instead, then you want to use a non-opioid analgesic on top of the opioid analgesics. Over time, there will become a bit of tolerance that will develop to sedation, respiratory depression, nausea, and vomiting. We don't see this tolerance to constipation or meiosis, which we talked about earlier. We can use complementary adjuvants to help with the effects of opioids. We can use them in combinations, but we don't use them as a substitute. They enhance analgesic from opioids. They can help manage concurrent symptoms that can further exacerbate pain, and they can also be used to treat the side effects that are caused by the opioids that we're using. Several of the adjuvants are especially useful when you have a patient that has neuropathic pain. they differ from opioids because the pain relief is limited and less predictable, and often it develops very slowly. So you don't use it by itself. And you want to use the analgesic ladder that was talked about earlier to help you to understand when you would use an adjuvant. It's really interesting, though, that they can relieve pain, but then also using them can further promote other conditions, or you can treat other conditions. According to this principle, it's important to reassure the patients that adjuvant use is in addition and can be used purposefully to alleviate their pain while they're using opioids as well. There's a table in your book that goes over the dosing in more specific detail. Now, antidepressants can also be used. Tricyclic antidepressants, or TCAs, can reduce neuropathic pain. They also have analgesic effects on their own that enhance the effects of opioids. And so they can allow the reduction of opioid dosage. If you use TCAs, you can use less opioids. As a side benefit, TCAs can affect their mood positively. It can elevate their mood. It can also help with the depression that may come with cancer. There are important adverse effects that you need to be aware of, though, when dosing TCAs. Orthostatic hypotension, sedation, anticholinergic effects can occur, as well as weight gain. Dosing it at bedtime is advantageous because there's already going to be a sedative effect, and this way it can minimize the sleepiness during the day, but also minimize hypotension that you would have if you dosed it earlier throughout the day. TCAs take a while for them to kick in, and you will start to hear about the effects in 1 to 2 weeks, and it reaches the maximum effect in 4 to 6 weeks. You can also see the dosing of TCAs in your textbook. Other antidepressants that you can use are bupropion. You can also use duloxetine and venlafaxine. These can also help with neuropathic pain, in addition to the TCAs, like amitriptyline. Anti-seizure drugs can also be helpful for neuropathic pain, especially acute pain like sharp darting pain. This is very responsive to anti-seizure medications. Cramping pain, aching pain, burning pain, all kind of describe this neuropathic pain. They all respond to anti-seizure medications like Tegretol. This is also called carbamazepine. It is probably the most widely used. Carbamazepine is myelosuppressive, so you want to use it with caution, especially in patients that are taking anti-cancer drugs for their treatment, because these anti-cancer drugs can suppress bone marrow function as well, and now you're giving them Tegretol, which is myelosuppressive. We also can use gabapentin, which is also called Neurontin. This is very effective. It has less side effects. I actually prefer gabapentin over Tegretol, but if your patient fails Neurontin, you can move up to Tegretol, or it's really based on your preference and what you think is going to work best for your patients. And lastly, there are topical anesthetics like lidocaine, or also the trade name is called Lidoderm. This is second-line agent for neuropathic pain, and you can put it topically over the area. It's a 5% patch that can be applied for pain. It works up to 12 hours, and lidocaine was touched upon in a different chapter. There are some central nervous stimulants, glucocorticoids, and biphosphonates that we can use. The CNS stimulants, like dexedrine and Ritalin, they actually have beneficial effects. They can enhance the opioid-induced analgesic effect. They can counteract opioid-induced sedation, and they can help with the patient's mood. The principal side effects, though, are loss of appetite, insomnia. This is because of the CNS stimulation that occurs, but this is also what's helping with sedation, causing a opposite reaction to the sedation. To minimize the interference with your patient's sleep pattern, you want to dose earlier in the morning and not later in the day. With glucocorticoids, they do lack a direct analgesic action, but they can help manage cancer-related pain because they're reducing cerebral and spinal edema. So for those patients that are experiencing that type of edema and pain, this is a good time to use glucocorticoids. You can also use them for emergency management when there's a patient with elevated ICP or intracranial pressure, epidural spinal cord compression. Glucocorticoids are also great to use. They're the standard therapy for tumor-induced spinal cord compression. Additionally, they can improve appetite, and basically with some patients that have taken glucocorticoids with this type of pain, it has improved just their general sense of wellness. So in terminal illness, we will sometimes see with our cancer patients anorexia and cachexia, and giving them glucocorticoids will actually help with these two things. It's very safe when used short term. You can even use high doses, but what you don't want to do is use it long term. Even when you use low doses, you still don't want to use it long term. And remember, you may need to taper to some extent. Long-term therapy can cause adrenal insufficiency, osteoporosis, glucose intolerance, so your patient would have hyperglycemia. And you're going to increase their risk and vulnerability to infection. We know all of this by understanding glucocorticoids already. Additionally, you might have forgotten that long-term use of glucocorticoids can thin the skin and can also increase the risk of PUD or peptic ulcer disease. The risk of osteoporosis can be reduced if you give calcium supplements and vitamin D, and you use it with calcitonin or biphosphonates. Biphosphonates can reduce cancer-related bone pain in some of the patients. And it's very common if you have cancers that metastasize to the bone. And that cause of pain can be a tumor-induced bone reabsorption causing hypercalcemia, osteoporosis, and related fractures. So by giving biphosphonate, you are inhibiting bone reabsorption, you're improving and treating actually hypercalcemia that's related to the malignancy and the bone metastasis. However, when these drugs are given to treat hypercalcemia, many patients report a reduction in bone pain, but some patients still do not. So it doesn't promise you that it will get rid of the bone pain, but it is some of a drug to consider if you have a patient experiencing bone pain. The next few slides are some of the tables that I alluded to earlier. This slide talks about the adjuvant drugs that can be used for cancer pain, and these drugs here are for the reduction of neuropathic pain. You can use TCAs and anti-seizure drugs as well as other antidepressants. This chart shows you the local anesthetics that can be used, like lidocaine topical patch, the CNS stimulants that we talked about, glucocorticoids, so mainly we're using prednisone and dexamethasone, and then the biphosphonates that are commonly used for bone pain. This last slide, or a couple slides here, have to do with non-drug therapy, just worth mentioning. The goal of using a neurolytic nerve block is to destroy the neurons that are transmitting pain. And it's from that limited area. It provides permanent pain relief, actually, because it's destroying the nerve. And you do this by injecting locally a neurolytic or a neurotoxic substance. Typically, it's going to be alcohol or phenol. And to make sure that the correct nerves are being destroyed, a reversible nerve block is done first to see if it's going to work. And you just use a local anesthetic. And if it relieves the pain, then they will put the neurolytic agent in that same place. And then the neurolytic nerve block eliminates the pain. And usually this helps for up to about 80% of the patients with the nervous type pain. However, let's say you put in the reversible nerve block, local anesthetic first, and you're only getting partial relief. Then you can still give, use this to reduce some of that pain, but it won't take away the whole pain. So you might be able to do this and then reduce opioid dosage, or you might be able to, because you decrease opioid dosage, decrease the side effects related to that. However, you're not going to get that full symptom relief. So you have to decide with your patient if this is what they want. When a nerve block is successful and opioids can be discontinued completely, you don't want to go cold turkey. You want to make sure that you taper the opioids gradually because you're trying to avoid withdrawal symptoms. It's best to educate your patients too on the risks with nerve blocks. There are complications that include hypotension, paresis, paralysis. You can also have a dysfunction in bowel and bladder. With radiation therapy, this can also relieve pain that's causing pain that's caused by cancer. And this pain that can be relieved by radiation is by allowing the radiation therapy to create a tumor regression. Palliative treatment can be directed at primary tumors, and then also you can use it for metastasis and other places in the body. And there's 4 forms of radiation that can be used. You can use the brachytherapy. Remember, this is the kind where you implant radioactive pellets. Pellet therapy is when you use that external beam radiation, radiofrequency ablation, and we have IV radiopharmaceuticals that can be used as well. I'm not going to go too much more in detail of this because it's more about the management of cancer itself and not so much the drug or the pharmacologic treatments. There is some patient education that can also be given because, even though you are going to focus on the pharmacological treatments in this class, you do still need to be able to give the risk and benefits and options for your patient. And the patient education is going to be the integral part of this cancer pain management. Sometimes you try to use non-drug therapies with drug therapy. Sometimes you aim for non-drug therapies after drug therapies can help subside that acute pain that they are experiencing in the moment. Whatever the case, your education needs to be accurate, comprehensive, understandable, and you want to reinforce the communication. You are trying to understand the nature, the cause of the pain. You're assessing the patient. You want them to honestly report what's going on. You want to provide a plan for both drug and non-drug therapy. Encourage them to express any concerns, questions, fears. They, again, very commonly, they will try to avoid opioids, most patients, because of their concern of tolerance or dependence. So please educate them with that as well. You want to reduce anxiety, dispel any hopelessness, facilitate that comprehensive assessment, enhance the compliance by giving them the information that they need. Written pain management plan is always necessary so that it can reinforce what you talked about. It doesn't allow any confusion. Also providing a check-in, frequent as you deem necessary with your patient and what they understand. It will decrease complications. It will also provide a sense of control for your patient when they're able to speak into their pain management.